Greetings from Indian Society of Gastroenterology. I am Matthew Philip, and I am the Secretary General of ISG. And this is actually a master class series 5, and we have been having master class on every 2 weeks. And today we have got a very important topic on Helicobacter pylori and its diagnosis and treatment. And we have Dr. Amit Datta as the moderator, and he's the professor at CMC Vellore, and he's a man of luminal gastroenterology, done pioneering works in luminal gastroenterology, and he has published a lot of papers on various aspects of this. And may I request Dr. Amit Datta to take over, introduce Dr. Usha Dutta, the speaker, as well as a topic. And I request all the participants to post their questions on chat box. We'll take up the questions one by one. Next slide. Dr. Amit.
Okay. So good afternoon, everybody. And first of all, thanks to ISG for inviting me to moderate this session. So for today's session, H. pylori, we have Professor Usha Dutta, who is the Professor and Head of Gastroenterology at PGI Chandigarh. She is a renowned expert in the field of H. pylori. She has done a lot of work in this area, and she's very passionate about this topic. We've heard her in the past as well. Her grasp of the subject is very well. And so today we are going to discuss on Helicobacter pylori. Now we know that more than almost half of our population has H. pylori infection. So there are a lot of issues when it comes to H. pylori. There are so many tests available. So how should we test? Should we test at all? How should we test? There are multiple treatment regimens available. There are issues about resistance. So again, deciding on what regimen to use is also important. Then there are issues about follow-up of the patients after they have therapy. So we'll hear all this from Madam, and we'll, at the end of the session, we'll have some clarity about all these issues. And as Dr. Matthew said, please post your questions in the chat box so that we can take up the questions. So over to you, ma'am. Yeah.
The admin, stop sharing your slides. Let Dr. Usha share her slides, please. Thank you. Dr. Usha, you are muted. Can you please unmute your phone? Yeah. You are muted. We can see that you are muted.
Yeah.
Yeah.
Okay.
Thank you.
Good afternoon, everybody. Thank you so much, Dr. Amit and Dr. Philip, for introducing this topic as well as myself. Really grateful to ISG for conducting these master classes for the benefit of the larger community of gastroenterologists and physicians. I think it's a very important topic today on H. pylori diagnosis and treatment. So this is the ISG master class. Helicobacter pylori is an old hardy bug. It is associated with the human gut for over 50,000 years. It is with mankind since the time man came out of Africa. It is the commonest infection in mankind. 50% of the world is infected, and it's actually a marker of sanitation status. It is not a commensal. So that is something we have understood in the last decade, that it is very clear with emerging evidence that if you see H. pylori, it is causing disease, it needs treatment. It enters without much fanfare, and that is why many of us never know how to handle it. So this bug comes through the mucus layer and enters it, degels the mucus layer and goes and sits between the epithelial cells and the mucus layer. And here it incites low-grade inflammation and survives on the cell exudate. And the onset is insidious, so many people do not realize when they got the H. pylori infection, and large number of infection can be also acquired in the young age as children, when children are moving around, and also fecal-oral transmission, with overcrowding increasing the rate of H. pylori infection. So here it is that it enters under the mucus layer, produces CAG, urease, VAC, and other LPS genes and has addition molecules. And here it continuously goes on inciting inflammation, and chronic inflammation can result in mutations and carcinogenesis in a small subset of patients. It may have symptoms only in about 20% of patients. That is why quite often it goes unrecognized. 80% are asymptomatic. Pain, nausea, vomiting, dyspepsia, non-specific symptoms may be the dominant symptomatology. But if you do biopsy in these patients, all of them will have chronic gastritis to a varying degree of inflammation. So H. pylori present means a damage to the host. It can be asymptomatic with antral gastritis only on endoscopy. There may be gastric atrophy. And in India, we see a large number of patients when we are doing endoscopy. There is gastric atrophy, and this gastric atrophy is of state. And here, what happens with the spiral state is this is susceptible to antibiotics. So whenever we give PPI therapy in these patients, there is increased proliferation of H. pylori, and thus it becomes susceptible to antibiotics. So what is new about this old bug? Management of H. pylori has changed with Maastricht 6. Also, several studies on antibiotic resistance in H. pylori has shown that the resistance pattern is increasing. There are several guidelines on it. And we also recently completed the Indian National Dyspepsia Task Force study from which we learned certain things. What we have learned overall is all patients infected with H. pylori need treatment even if they are asymptomatic. And the resistance pattern is increasing and the resistance pattern is changing. The very important study which came from Taiwan, it showed that once you eradicate H. pylori, the incidence of gastric cancer goes down in the community. There was a 53% reduction in gastric cancer from 2004 to 2006, when a large population of 16,000 were tested and targeted and treated for H. pylori with eradication. So there has been this eternal debate to treat or not to treat. What we find is, though people have said that increases the cost, increases logistics, increases resistance, increases reinfection, increases recrudescence, but the benefits outweigh the risk because it does reduce symptoms, it decreases the incidence of cancer, it decreases ulcers, decreases bleeding, and decreases iron deficiency. So the consensus is to treat. If you see H. pylori, we should treat it. And it is also WHO has declared it as a class 1 carcinogen, indicating that this should be treated. So the issues are whom to test, whom to treat, how to treat, and how to test for eradication. So who should be tested? Anybody during endoscopy has features of antral gastritis, anybody who has evidence of gastric atrophy, anybody who has an ulcer, anybody who has a malignancy, either adenocarcinoma or a lymphoma or a malt lymphoma should be tested for H. pylori and if present should be eradicated. What is the relationship of H. pylori and gastric cancer? H. pylori, if it is associated with atrophy and intestinal metaplasia, such stomachs are at 5 times increased risk. If there is pan-gastritis, it's 15 times increased risk. If it is a corpus dominant gastritis, it's 34 times increased risk. And eradication decreases the neutrophil inflammation by about 4 weeks, decreases the lymphocytic inflammation by 1 year, and causes regression of atrophy. Usually, once you have intestinal metaplasia, there is no regression. Eradicate early because so that it can give us better benefit. So in dyspepsia, it has been shown that those with dyspepsia who are young, who don't have alarm symptoms, who are having low prevalence of gastric cancer and high prevalence of H. pylori like India, we should look for H. pylori by a non-invasive test like stool antigen test and a urea breath test and treat if we find. If the patients come from a region where it is high prevalence for gastric cancer, low prevalence for H. pylori, and there are alarm symptoms, or the person is aged more than 55, we should subject them to endoscopy, test for H. pylori, and treat. What has the benefit of treatment? It reduces 10% reduction in symptoms. The number needed to treat is about 14, and there's 25% reduction in consultations in over 7 years. And as you saw, it takes 1 year for the lymphocytic inflammation to go down. So it's a more cost-effective approach in India as well as in Asia because there is a high prevalence of H. pylori and treating it is going to help us. And it also restores the normal acid secretion, which is required as a protection and a barrier to the excess of fecal-oral transmission, which happens in the underdeveloped countries. Whom to test? Those with iron and B12 deficiency, which is not responding to therapy, those with ITP, those with family history of gastric cancer, those on NSAIDs and anticoagulants, they all need to be tested and treated. Before we start NSAIDs, especially in patients with chronic knee pain, hip pain, there is an increased risk of ulcer bleeding if they are H. pylori positive, and thus these patients should be tested by a non-invasive test and eradicated if present. As we discussed that patients with dyspepsia, according to Rome 4 also, it is very clear that before we label them as functional dyspepsia, we should test for H. pylori, and if it is present, it should be eradicated. So no longer should we label patients as functional dyspepsia in the outpatient without testing for H. pylori. Also, it's very important that patients with dyspepsia, before we start empirical PPI, it is important to exclude H. pylori because if we give empirical PPI for patients with dyspepsia, you're increasing the risk for cancer downstream. So it's very important that such patients are tested and treated. How to test? So for diagnosis, we have, if you're planning an endoscopy, it is very clear, you do an rapid urease test and a histopathology. A routine histopathology with H&E section with a trained pathologist is sufficient for us to diagnose H. pylori. It's also important to ask the pathologist to use the updated Sydney classification and tell us whether it is corpus dominant gastritis, antral gastritis, pan-gastritis, are there neutrophils or not, is there chronic inflammation or not, is there intestinal metaplasia or not, and are they seeing H. pylori? So this is the information we need from our pathologist. We can use rapid urease test in all these patients because it is a point of care test. It can be assessed by the endoscopist in about 30 minutes. He can report, and this is useful to start the patient on therapy immediately. If we are not planning an endoscopy, you're seeing the patient in the outpatient and there is no indication for endoscopy, please do not do an endoscopy. In these patients, easily we can do a stool antigen test and a urea breath test. Whichever is available at your center, you can use. So there are certain caveats for both of these. I'll come to that in the next slide. And if in the community we are looking for prevalence, we can use serology. The other situation where serology is useful is patients who have CS stomach or lymphoma and the H. pylori has migrated upwards and you're not able to detect it, or the amount of H. pylori has gone down, or the situation is that the situations become so hostile that you can't really detect H. pylori except for by PCR or by serology. So which test do we have? Urea breath test has 95% sensitivity and specificity. It's easy. It's an office-based test, but it needs a high load of minimum 10 to the power 5 per gram tissue. So it can be used for diagnosis as well as eradication. But there are challenges nowadays in availability of urea breath test, and this is creating an issue. But otherwise, what I'm finding very useful is a stool antigen test. Stool antigen test for H. pylori is specific, sensitive, and is a very useful test. It is underutilized, but we have made it now a routine in our department to use it for diagnosis as well as eradication. The most important thing to see that the stool antigen test is validated for your own place where you're using it. Serology, as I said, it remains only for prevalence. It cannot help us. Even after eradication, it will remain positive. So it doesn't help us in active infection diagnosis or for eradication. Rapid urease test has a 90% sensitivity, 98% specificity. For a rare chance, other urease producing organism can also be positive, but the dominant organism which produces urease in the stomach is H. pylori. It helps us with prompt diagnosis and can also use for eradication. However, we do not use it for eradication because it entails one more endoscopy. The only situation where we will use RUT and repeat the endoscopy is when we see a patient of gastric ulcer and H. pylori was positive. It is mandatory to repeat an endoscopy after 8 weeks to document that the ulcer has healed. A gastric ulcer is not always benign. It may have lurking malignancy. So whenever we see a gastric ulcer and RUT positive, such patient needs to be on very close follow-up with repeat endoscopy to document complete healing. Histology, as I said, is useful, and we have standard HNE as well as special stains, but quite often I find a pathologist, if they are dedicated to look for H. pylori, a standard HNE stain is sufficient to make the diagnosis. Culture has only 40% sensitivity, and it's also cumbersome. It needs a microaerophilic and anaerobic incubation. So there are issues, but culture is useful whenever we are looking for resistance. Slowly, culture is getting replaced by PCR-based tests for diagnosis as well as for resistance assessment. What are the caveats for a rapid urease test? You need minimum 10 to the power 5 H. pylori organisms per gram of the biopsy tissue. Also, the agent that we use should be kept in a warm temperature for the incubation so that we get positivity. Quite often, our endoscopy rooms have very low temperatures, and in such temperatures, you may get a false negative rapid urease test because the urease enzyme is not effective at such low temperatures. So what we do is we take the test and put it in an incubator or keep it in a warm room for us to check for the change in color. The change in color is fairly dramatic. And what we have done is we use antral biopsy and fundic biopsy. So we put 2 biopsy tissues in one well. So this increases the yield and also picks up those H. pylori which have migrated to the fundus. Also, patients, before we do rapid urease test, should be off PPI, should be off antibiotics, should have not had a recent GI bleed. These things can falsely affect the rapid urease test sensitivity. So we usually ask the patients to be off PPI for minimum of 2 weeks, antibiotics minimum of 4 weeks before we test for rapid urease test. H. pylori detection by PCR is now becoming a very prominent method for us to make a diagnosis as well as to test for resistance. It's fast, it's accurate, and you can get the result in same day, especially if we are doing a LAMP PCR. PCR-based detection, we can use the gastric biopsy or use the gastric juice or the stool specimen to detect H. pylori. There are several target genes like CAGE, VACA, urea, HSP17, 16S RNA, and 23S RNA. Any of these genes can be tagged. Sensitivity and specificity is of 95 to 100%. Stool specimens have lower sensitivity because there are certain inhibitors to PCR in the stool. The minimum number of H. pylori you need in the gastric fluid to detect is as low as 15 colony forming units per ml. In a biopsy, about 150 colony forming units per ml, and in the stool, 1,500 colony forming units per ml. So this is very important that with very little amount of bacteria, you can pick up with PCR. What is a policy we should follow for testing? Patient should be off antibiotic for 4 weeks, no PPI for 2 weeks. This is a problem whenever we schedule patients for endoscopy. Patients are already on PPI and it's very difficult to take them off PPI. So what we usually do is we advise them to be off PPI. We ask them to be on ranitidine or on some antacid preparations for about 2 weeks so that we optimize our increased yield for RUT. And then after 2 weeks, we test them either by urea breath test or a stool antigen test or an upper GI endoscopy with a rapid urease test. A recent study from PGI, which we are in the form of publication, this shows that even in patients on PPI, if PCR still remains positive when RUT is negative. So this is another role of PCR in picking up small amount of organisms for even if they are already on PPI. And if it is positive, we have already discussed, we should be treating. Seropositivity does not need treatment except in situations where I would say there's a family history of cancer, or if there is a history of a gastric ulcer, or there is malt lymphoma, or there is PA stomach. Only in subset of these kind of patients should we be treating seropositive. Otherwise, it is not indicative of an active infection. So how to treat? Which drugs, what dose, what regimen, what duration, who needs testing for resistance, and how to tailor it in India?
Yeah,
So
Dr. Usha, at what time we should take the questions? And if we are planning for treatment now, can we take the questions for diagnosis now?
Sure, sir.
Dr. Amit? Dr. Amit, are you there? Is there any questions which has come on?
Yeah. So thank you. Yes, sir. So I would request the participants to please post their questions. Meanwhile, Dr. Matthew Philip has a question. What is the suggestion about testing the family contacts for the people who have H. pylori? And if you want to test the contacts, what test should we use? Yeah.
Very interesting question and something which is very relevant. I do think that since there's fecal-oral transmission, we could test the family with either a urea breath test or a stool antigen test. Patients prefer urea breath test because it is not messy with giving fecal samples. But I would think whatever is available in your setup, whatever the patient's relatives are acceptable, because there is a high chance that there is an intrafamilial transmission of H. pylori. And I think it is a very important point Dr. Matthew has raised. I think we don't routinely test, but I think like hepatitis B, it has become a part and parcel that we should do family screening. For H. pylori also, we should go to the next step of family screening.
I just want to whether serology testing is sufficient for them. That's why, because we cannot do any other, or you should go for H. pylori stool examination. What is your recommendation?
Sir, I would think that serology testing again will not tell us they have active infection.
I agree.
So if we have to treat, go to the next decision step, it is important to get either a stool antigen or a breath test.
Okay.
So another question from Dr. Matthew Philip is that, when somebody comes with acute GI bleeding, like ulcer bleeding, that time the tests will there is the chance of getting a false negative in those situations. So in those patients, will we empirically treat for H. pylori, considering H. pylori is the dominant cause of ulcer disease? So ma'am, what's your take on that? Yeah.
Yes, again, a very relevant question. So suppose you're doing endoscopy, patient has come with a GI bleed. and you have done some endotherapy for that, people have shown that if you studies have shown that if you eradicate H. pylori, the chance of recurrence of bleed decreases. So if I'm doing an endoscopy and patient is not on NSAIDs, patient doesn't have any other risk factor for ulcer, the highest probability is that the etiological factor is H. pylori. So what I usually do is take biopsies from the fundus, send it for histopathology and RUT, knowing fully well it may be underrepresented on the histopathology at that time, and we can empirically treat for about 2 weeks, because anyway we are giving PPI. It's a question of adding 2 antibiotics, and patients who are having variceal bleed in the setting of cirrhosis, anyway antibiotic is given. So for the non-variceal bleed, here adding 2 antibiotics with the PPI for about 2 weeks is a good option to consider. And that is the thing which I follow, especially when I'm seeing an ulcer and the stomach looks as if there is H. pylori. We can put in an NBI and see the stomach and see if there is any features to suggest H. pylori gastritis. And if it is there, then it's a good idea to treat them.
So, ma'am, thank you. Next question is, what is the significance of intestinal metaplasia on biopsy in H. pylori infection? That's the next question.
Yes, that is again a very relevant question, as I emphasized that the pathologist should report on presence or absence of intestinal metaplasia, and the endoscopist should take a biopsy from the incisura to look for metaplasia, because it is the incisura of the stomach which has the highest risk of having metaplasia. So if we find intestinal metaplasia, such patients should be tested for H. pylori, eradicated, and retested whether the intestinal metaplasia is increasing, static, or is it regressing. Usually we don't get so much of regression, though a few studies have shown a small percentage of patients after eradication over a period of time show regression of metaplasia. However, most studies indicate that after you eradicate H. pylori, intestinal metaplasia continues to stay, but doesn't remain as sinister as it would have been if there was ongoing inflammation due to H. pylori. So the bottom line is, look for metaplasia. If it is there, treat. And such patients with intestinal metaplasia should be under close follow-up to look for any emerging malignancy and recurrence of infection, and the eradication should be confirmed after we eradicate H. pylori in this subgroup of patients, definitely.
Thank you. Actually, yeah, ma'am. So I think the H. pylori definitely doesn't have much role in the metaplasia, but there are some, as you say, follow-up studies where they have shown in some cases metaplasia may regress, but generally it persists actually. So another question about number of samples for RUT. You already said that you take a couple of samples. Just want to reiterate that point. For rapid urease test, how many samples we take from the stomach, ma'am? Yeah.
We take routinely one from the antrum and one from the fundus and put both of them together in the same well. So what we find is that in India, invariably a large number of patients have taken PPI. It's available over the counter, in contrast to the West, where PPI is only a prescription medication. In India, quite often patients are usually on PPI when they come to us with dyspepsia symptoms. So our H. pylori is suppressed when they are on PPI. So in such situations, one biopsy from the antrum, one from the fundus, a combination of these two in the RUT well will improve the yield.
Thank you, ma'am. So actually, there are a couple of questions about therapy, which I think we'll take up once we discuss about therapy. Another question is, if we are like Dr. Matthew Philip is saying that, like we said, one test we'll do, but when it comes to say doing a research on H. pylori, in that setting, would you like to do more than one test, or is one test sufficient?
Again, it has been a dictum that we should show H. pylori by minimum 2 tests. And, that was an era when we were not sure whether we should be treating H. pylori always. So that's why people wanted double confirmation. At that time, our studies were not, the tests which were used was not of very high sensitivity and specificity also. So I think slowly the paradigm will change. But what we usually use is to diagnose one test is sufficient. For research purposes, it is still the old algorithm which is followed of 2 tests. So of the 2 tests, if one is serology, we definitely need another test. But if we have rapid urease test positive or stool antigen positive, I think it is sufficient for treatment. For research purposes, we can get it validated by doing 2 tests.
Actually, as you said, because most tests have more than 90% sensitivity specificity. So ideally, it should be like there will be good tests if you have such high specificity sensitivity and for even research. But I think as of now, as you said, people still expect a couple of tests when you're publishing for a research purpose. Then the next question is that, so I think probably you have recommended, the question is, do we need to test H. pylori in all patients with dyspepsia?
Yes, Amit, I think Dr. Amit has raised the very controversial point, which has been a matter of controversy 20 years back, 10 years back, but today there is no controversy about it. All patients of dyspepsia, whether it is Maastricht 6 or it is Rome 4, or from whatever our experience is, that we should be testing all patients with dyspepsia. In India, I will just show you our study. About 30% of patients who are just walking into the OPD and having dyspepsia, 30% are H. pylori positive. An additional 15% got detected by the PCR-based tests. So I think a fair proportion of our patients are having dyspepsia. In our country, the epidemiology is changing. Maybe in about 20 years, the incidence of H. pylori may go down. But actually, if you see the way most people are still living in the rural communities, suburban communities, and in various kind of slums and various things, you can see that fecal-oral transmission in our country is still rampant. So we cannot get away from testing patients with dyspepsia of H. pylori. In Taiwan, China, Japan, they have gone to the masses. They have gone door to door, checking for H. pylori and eradicating, so that they can reduce stomach incidence. But in India, I think we still are, debating about whether in dyspepsia we should test and treat. My feeling is that we should test all patients with dyspepsia. This is what the literature shows, and we should test and treat if they are having H. pylori.
I think this also answers another question which somebody raised about, should all dyspepsia undergoing endoscopy be tested? So I think when you do endoscopy, then we should do RUT as you're suggesting. And there's one question about liver cirrhosis, like patients who have liver cirrhosis, and we find sometimes mild PHG, non-erosive gastritis. So in those patients, do you check for rapid urease H. pylori in those patients? Do you check for that?
Yes, very important. I think 2 very important issues have come up. One is all patients, when we're doing endoscopy, we should test for RUT. And I would here have a caveat that your quality of the RUT test that you use is very important. Either you have an in-house standardized system or you have a commercial one, and the commercial one should also be of good quality so that it can pick up what we are looking for. So I insist on quality RUT kits, whichever you're using, and ensure that the temperature in the endoscopy room or the side room is maintained at slightly higher temperature, maybe about 25 degree, so that we can pick up the RUT positivity. And regarding cirrhosis and PHG, there is now emerging evidence that even in patients with cirrhosis and PHG, H. pylori may have a role in the whole process of pathogenesis. There's increasing literature and evidence that H. pylori may be one of the agents in the whole process of gut barrier disruption, as well as inflammation, which persistent gastric inflammation. And here again, testing it, and we have to be very careful that when we take a biopsy, we are not near any varix, and ensure that we should take it more from the fundic area and put maybe 2 biopsies from the fundus, or 1 from the antrum and 1 from the fundus, again for a rapid urease test. But we should be careful that we don't include blood in such a kind of specimen, because that can give us a false change in pH.
And the next one is like if somebody who's requiring a long-term PPI and because of symptoms, they are not able to stop the PPI. So in those patients, how do you handle testing, or will you sometimes go for empirical therapy? That's the next question in the chat box.
I think it is, if patients are on PPI, we can shift them to ranitidine plus antacid combination. But if we can't, then PCR-based tests are better methods in this. The third method, as we do, is antral biopsy and fundic biopsy, both at the same time. And stool antigen may be able to pick up even smaller loads of the bacteria. So my dictum in this situation is try and speak to the patient. If that's just not possible, then use a PCR-based method or increase your sensitivity of the rapid urease test by minimum putting double tissue into the well.
Another question is that if, like, we do sometimes two tests. So if somebody has a couple of tests, for example, they say biopsy and RUT. RUT turns positive and biopsy, you don't see the organism. So will you treat what will you do in such? You'll repeat test, or will you sort of, yes.
Yeah, again, a very relevant question. And as I said, RUT positivity in the stomach usually indicates that it is a urease producing organism. In the stomach, in that kind of environment, the dominant urease producing organism is H. pylori. So I would think that it means there is active H. pylori infection in the stomach and it should be treated. There is a discrepancy sometimes between RUT and histopathology, because sometimes histopathology, gastric biopsies are such common samples which the histopathologists get. So unless they diligently are looking for H. pylori, you may miss that. And it also depends, unless the endoscopist is asking for H. pylori presence or absence, sometimes it may miss the attention of the pathologist. And there's also a sampling error. So we may end up having a situation of RUT positive but H. pylori negative on the histopathology. So in such situations, I think I would go ahead and treat.
That's very relevant, because I think pathology, from what I hear from them, at least 100 field you have to look at in your specimen. So a lot of fields they have to examine. It's a very painstaking, time-taking job. So sometimes you may not pick up. So therefore, I think that also factor has to be considered. Another question about role of narrowband imaging in diagnosing H. pylori infection.
I'm sorry, I missed that aspect. I should have put a couple of slides on that. Narrowband imaging is a very useful technique and can be just easily added on to the endoscopic examination. And nowadays, most of our scopes have narrowband imaging. And narrowband imaging can give us an indication that there is H. pylori. So we use narrowband imaging to, tell us, okay, this is a good area to target for taking for RUT. This is a good area to target for taking a biopsy for intestinal metaplasia. This is a good area to target where we may find H. pylori on histopathology. So definitely narrowband imaging gives us an indication that there could be lurking H. pylori and make us more alert to ensure a more specific diagnosis for H. pylori. I would not treat a patient for H. pylori just based on narrowband imaging. Use narrowband imaging as a screening technique during endoscopy, as well as a targeting technique during endoscopy.
Also, Usha, Dr. Amit, see,
Yeah.
even in white light endoscopy, looking at the regular arrangement of collecting veins, then you can say that probably there is H. pylori or not. Even on white light endoscopy, sometimes beneficial to look for H. pylori. And the body, the body of stomach, you can look for the vascular pattern, and probably that could tell.
Yeah, very true. I think one of the very, sensitive finding has been this absence of collecting venules, which they found in NBI. Only, I think, I was saying that difficult to differentiate whether it's a current or a past infection, because sometimes the changes may persist despite infection going away, although there's a thing. So therefore, I think for treatment decision, better to check for an active infection, like what Dr. Usha was suggesting.
Yeah.
Another question, ma'am. This is like somebody has a significant reflux esophagitis. Do those patients need testing for H. pylori?
Yeah, again, this has been a matter of controversy whether patients with GERD giving anti-H. pylori therapy, does it increase GERD? So this is what was literature about 15, 20 years back, bringing on this controversy that patients with GERD, we should not be eradicating H. pylori because the symptoms of GERD will go up. However, subsequent studies have very clearly shown that patients of GERD, when they are tested and treated for H. pylori, actually over a period of time, the symptoms of GERD goes down. So that is one point. And second is that patients with GERD, when they are undergoing endoscopy, as I said, it is a good practice to take a biopsy for RUT. As I said, that any patient, when they're undergoing endoscopy, it's a good clinical practice to take a biopsy and put it into RUT.
And in fact, actually, some of the severe esophagitis patients may need a long-term PPI. And I think you were flagging about, if you take PPI long-term, and H. pylori is there in the stomach, the risk of cancer may be higher, actually. So, do you think if somebody needs a long-term PPI, that may be one group where you want to check for H. pylori as such?
Yes, I think that is again a very important point raised by Dr. Datta. Here, I would agree with you that any patient who's on empirical long-term PPI, it increases the chances of H. pylori-induced gastritis as well as H. pylori-induced malignancy over a period of time. So such kind of patients should be tested, and it's a good practice to do RUT for patients who are having GERD requiring long-term PPI. And when you're anyway doing an endoscopy, taking a biopsy from the antrum and the fundus and putting it into RUT doesn't take any additional time except for maybe a minute or two. And RUT kits in India are about 150 rupees. And you can also have an in-house RUT kit, as Dr. Amit has in his own hospital. So whichever method you use, I think the cost benefit analysis for testing is very, very favorable towards testing in these patients.
Professor Datta and Dr. Usha and Dr. Amit, I think we can stop at this level, question answer. We will resume our Professor Usha's talk, and then we will have question again after half an hour. Okay, so we'll finish off the treatment part now, and then we'll take up the questions. Thank you. And I request all the participants to put more questions on the chat box. We'll try to finish up all the questions which are posted there. Thank you. Dr. Usha, please.
Thank you. Thank you, sir. It was a welcome break, and also we could discuss certain issues before we go on to treatment. So treating H. pylori is another challenge because the doctor may be complacent about the H. pylori. The bug is a very hardy bug, and patients often are not compliant for a 2-week therapy, and there is increasing drug resistance. My feeling here is to hit hard until it is gone, and hit early and hit well at the first time so that we can get away from this situation. So what are the drugs we have? We have proton pump inhibitors, metronidazole, clarithromycin, and amoxicillin. We have the quinolones, the rifabutin, the bismuth, the probiotics. These are used more in the second line, and these are used more in the first line. PPI has a cornerstone for H. pylori therapy. It is more important than the antibiotics. And that is what we have realized, that what PPI does is it pushes the H. pylori from the spherical state, which is the non-replicative state, into the replicative state. And all antibiotics will work only when the H. pylori is in its replicative state. So PPI pushes the bacteria into a replicative state, making it susceptible to antibiotics. So that's point number one. Point number two is it also helps in healing the gastritis, which is coming on because of the acid insult, which is initiated by H. pylori. The third is that it prevents clarithromycin resistance by inhibiting the efflux pump. It also improves the efficacy of amoxicillin as well as tetracycline. So PPI has a cornerstone, is the cornerstone for treatment of H. pylori disease. Which PPI? So PPI eradication rates, when you compare it with PPI and amoxicillin, with omeprazole, it is only 20%. With a high dose omeprazole, 40%. With esomeprazole, 40 milligram BD, it is 60%. With vonoprazole, 20 milligram BD is 90%. So as we increase the dose and as we change into newer and newer PPI, we have increasing eradication rate. So the newer generation PPI, rabeprazole, esomeprazole, and vonoprazole are also not affected by the CYP polymorphism. Interestingly, vonoprazole is not affected by meals, and hence the drug of choice which is emerging is vonoprazole, looking at the literature over the last 5 years. Vonoprazole has better acid suppression. It is rapid in onset, and it is potent. And it is not influenced by meals. It is not influenced by CYP polymorphism. It is stable in acidic condition, and it has better nocturnal acid suppression. And its eradication rates are higher, 93% versus 76% for lansoprazole, and also has better healing rates for severe reflux esophagitis from 88 to 96% on this arm versus 54% to 82% on this arm. Now you see most of these studies have been done with either lansoprazole or omeprazole as comparators. But if we use esomeprazole compared to that, also vonoprazole network meta-analysis shows better eradication rates and better healing rates with vonoprazole compared to esomeprazole. So the Maastricht 6 Florence consensus in 2022 published in Gut also says that the PCABs, that is these potassium channel inhibitors that like vonoprazole, is superior and not inferior to the conventional PPI-based triple therapies for first line and second line therapies, especially in places with resistance. So how do we interpret it for India? In India, we have increasing resistance. I'll show you the data. And we are having esomeprazole freely available. Recently, vonoprazole has been introduced into the market. Vonoprazole has shown better efficacy compared to the standard PPI. So we have to take a call here whether we should be shifting to vonoprazole-based therapies for minimum H. pylori eradication. It has been licensed for use in India, and now it is freely available. In Japan, Thailand, and other places, they have shifted to vonoprazole-based therapy for H. pylori. And I think in India, things are going to be changing soon. Several RCTs have also shown that vonoprazole-based therapies are efficacious and are more effective than the standard PPI-based therapies. The side effects are also lower and has good patient tolerability. And now we have sufficient data and large number of patients on vonoprazole that it is safe also. So this is a network meta-analysis, and you can see that the vonoprazole-based quadruple therapy for 2 weeks is more efficacious than the standard PPI-based quadruple therapy. And if we see the Sucra A, and this is a network meta-analysis, which is again shown that vonoprazole-based 2-week therapy with bismuth has one of the highest efficacies. So this is a forest plot, and here we can carefully see that PPI-based quadruple therapy for 2 weeks. Here you have the forest plot. This is at 1. So anything more on this side is going to be more efficacious. Anything on this side is going to be less efficacious. And if it crosses the line of confidence, we still haven't established that it is more efficacious. But here you please note that compared to PPI-based quadruple therapy for 2 weeks, which is our standard therapy, which we have been following, and it has a fairly large sample size. So this has a good weight for this meta-analysis. And here when we see that the vonoprazole-based quadruple therapy for 2 weeks is showing a higher efficacy, 1.10. And if we see here, the vonoprazole-based triple therapy for 1 week is also showing efficacy. Vonoprazole-based triple therapy for 2 weeks is showing a Sucra of 94.7%. So highest Sucra indicates this is the most cost-effective and time-effective therapy. So vonoprazole-based triple therapy with 2 weeks will give us the highest benefit for cost as well as efficacy. Coming to the next drug, that is amoxicillin. Amoxicillin is a very important drug and resistance is fairly low. In India, resistance is higher than what we see in the Western counterparts, but however, it still has low resistance for us to be using it routinely. It inhibits the cell wall synthesis of H. pylori and prevents clarithromycin resistance in a dose of 1000 milligram BD. So no longer should we be using 750 milligram BD, except with people of very small frame and less than 40 kg weight. So here usually we use 1 gram BD. There are studies which have shown 3 to 4 grams are also highly efficacious, but many patients may not tolerate such high doses and may develop diarrhea. So that is why 1000 milligram BD is a good option to go with. And amoxicillin also inhibits the clarithromycin efflux pumps. So amoxicillin and clarithromycin together have synergistic action. Clarithromycin inhibits protein synthesis in a dose of 500 milligram BD and has been a very useful drug. However, the pattern of using clarithromycin is going to change because clarithromycin resistance is increasing in India, and because of a lot of over-the-counter prescription of azithromycin and our respiratory physicians prescribing a lot of azithromycin, clarithromycin resistance may change over a period of time and our usage may also change. Metronidazole has free radical damage to the bacterial DNA, doesn't get metabolized in the human cell in a dose of 500 milligram BD. And metronidazole again was found to be a useful drug in about 20 years back. However, resistance is about 80%, so usage is of no use in our country. So what are our saviors when we have resistant H. pylori? We have quinolones. It inhibits the bacterial DNA in H. pylori by inhibiting the DNA gyrase and the topoisomerase 4 enzymes. Levofloxacin and moxifloxacin are good alternatives. But the problem with levoflox is, again, it is an important drug for our antitubercular range, as well as used as first-line therapies by ENT specialists as well as respiratory specialists, and levofloxacin resistance is also increasing in our country. So in the West, they use it as second line, but in India, we may have some challenges in using levofloxacin. Rifabutin is a very useful drug for third-line therapy of H. pylori. It inhibits the DNA-dependent RNA polymerase of H. pylori, and more importantly, it gets concentrated in the gastric juice to as high as 10 times. It's chemically stable, resistance is very low, less than 0.1%, and it is useful in a dose of 150 milligram BD. The problem with rifabutin is purchasing it in open market sometimes can have challenges. Internet sources are available, and if we tell our local stockists to keep it, they usually stock it. And so the main thing about rifabutin should not be used routinely, should be used as an important reserve third line drug for managing H. pylori. Bismuth is a very important agent. It inhibits the enzyme urease, catalase, and lipase. It inhibits the adherence of H. pylori to the surface epithelial cells. It overcomes clarithromycin and levofloxacin resistance. It is not affected by metronidazole resistance, and hence is emerging as a cornerstone in India for treating H. pylori. And the more important thing is that bismuth is a safe drug, and it is also not does not have high resistance. Bismuth resistance is not known, and it can be used in two forms. That is the colloidal bismuth subcitrate, 120 milligram 4 times a day. It can be also 240 milligram twice a day, and bismuth subsalicylate, which is not the common form of drug we get in India. Clinicians used to hesitate using bismuth. In the West, bismuth is available over the counter. Patients get some black stools, but if you just caution them about that, they're comfortable with it. And it is initially pharma industry was not very keen on it because it was low cost, high profit. But bismuth is now become available in Indian market by about 2 or 3 pharma industries. So it is useful in the treatment of H. pylori. There has been a lot of buzz about probiotics, but probiotics have several mechanisms of action, but its efficacy, which it adds, is about 10% to the existing therapy. So in difficult to treat H. pylori, we can consider probiotics, but it is not to be recommended in all patients. Which regime and what duration? What are the standard regimes we used to have? We used to have the standard triple therapy, which had 3 drugs in the first week, and again the same 3 drugs in the second week. We had sequential therapy where you had 2 drugs in the first week and 3 drugs in the second week. Hybrid therapy where you had 2 drugs in the first week and 4 drugs in the second week. Concomitant therapy, which had 4 drugs in the first and the second week. And the bismuth quadruple therapy, which was usually 4 drugs containing bismuth. Now, what are the drugs in all of them? You see, there is PPI in all of them. The other antibiotics are either amoxicillin, clarithromycin, or amoxicillin, followed by the next, in the second week, PPI, clarithromycin, and metronidazole in sequential therapy. And in hybrid therapy, it was followed by 4 drugs. The rationale for giving PPI and amoxicillin in the first week was to push the H. pylori into a replicative state so that then the antibiotics can act. But practically, it has been shown, as well as in network meta-analysis, that concomitant therapy is better than all other forms of therapy in terms of its efficacy. So this is another meta-analysis which has shown that the vonoprazan-based triple therapy is better than the standard PPI, amoxicillin, clarithromycin. So in India, we have been using PPI, amoxicillin, clarithromycin as our first-line therapy, and that is where vonoprazan-based triple therapy scores over PPI-based, amoxicillin, and clarithromycin-based therapy to increase the efficacy. What these meta-analyses have all shown that quadruple therapy is better than triple. Bismuth is better than non-bismuth based. Clarithromycin is better than non-clarithromycin, and vonoprazan is better than non-vonoprazan based therapies. However, for clarithromycin in India, there is a caveat because of increasing as well as variable resistance pattern. We have to be very careful, and we may have to shortly drop clarithromycin unless we test for sensitivity in our patients. Meta-analysis have shown that 14-day therapy is better than 10 days, which is better than 7 days. So gone are the 10 days and the 7-day therapy. So 14-day therapy, as I said, hit well hard as early enough. So 14-day therapy is a better option than 10 or 7 days. There's emerging problem of resistance because of which we need to consider and assess. Either you can use it by the disk diffusion method, the E-strip method, the PCR method, or the LAMP PCR. So these two are molecular based, and LAMP PCR compared to PCR gives us results very soon within an hour and doesn't require very expensive setup and can be easily done and can also tell us the resistance pattern. So in our recent Indian Dyspepsia Task Force, we used LAMP PCR to pick up H. pylori as well as H. pylori resistance to clarithromycin, and this data I will just share with you. H. pylori resistance detection by PCR. Clarithromycin resistance can be detected by a point gene mutation, detects about 90% of the clarithromycin resistance. Multiplex PCR can pick up clarithromycin and levofloxacin resistance, and the resistance detection can be done in the stool or in the tissue. Tissue is far better than stool. Stool, as I said, has inhibitors for PCR, and the tissue biopsy specimen gives us better results for resistance testing. H. pylori resistance is a large Spanish study where they studied 616 patients, where they did gastric biopsy, molecular as well as culture sensitivity testing, and found that the PCR picks up more than the culture. So that was point number 1. As well as the sensitivity and specificity for picking up resistance was as high as 100% and specificity between 80 to 100% for levofloxacin and clarithromycin. So the way to go for testing for presence as well as for resistance is molecular method and not culture method. There's problem of multi-drug resistance also, as well as biofilm formation. These multi-drug resistance are a very serious issue, and we are getting combined resistances for several agents. Because of these biofilm formation, there's a niche for the H. pylori and other bacteria all following into the biofilm, and these do not allow the antibiotic to penetrate inside and has become a very important defense mechanism by H. pylori. And this biofilm, anti-biofilm, there are several things which are being explored, including probiotics to break this biofilm. And I said the bacteria moves from the spiral bacillary form to the coccoid form, and the coccoid forms are not susceptible to antibiotics. So these are big issues which are the way H. pylori is fighting back to stay on. So there are several mechanisms of resistance for clarithromycin, metronidazole, quinolones, amoxicillin, and clarithromycin. So clarithromycin is through these efflux pumps, and amoxicillin is by changed permeability of the cell membrane. Also for the quinolones, and there's plasmid-mediated resistance and these ribosome-mediated resistance. So here there are several mechanisms which are acting, and this is a very important issue we need to work on. And as I said, H. pylori biofilm is an important mechanism for MDR and is a complex ecological system. These sessile bacteria, they are not adhered to the cell membrane. These are sessile and they are protected by the surrounding matrix. There are about 100 to 1,000 times more resistance. And biofilms on gastric biopsy specimen, 98% positivity in H. pylori positive, whereas only 1.6% of the gastric biopsies have biofilm when they are H. pylori negative. So H. pylori promotes biofilm, and the biofilm allows H. pylori to stay within the gastric mucus layer. And resistance pattern in Asia Pacific region is rising. You can see that the red bar tells us about the metronidazole resistance, which is fairly high in the Asia Pacific area, and clarithromycin resistance is also steadily rising to about 21%. WHO says that anything more than 17% should be considered as clarithromycin resistance. India is getting there, and levoflox resistance is also steadily rising to about 27%. So metronidazole, levofloxacin, and clarithromycin are posing challenges for us to use these as first-line therapies. Clarithromycin resistance, as I said, previous study has shown 17%, and a recent study from Bhubaneswar in India showed that clarithromycin resistance was 34%, amox 3.1%, levoflox 65%, and metronidazole 80%. So levoflox and amox cannot be a part of our standard therapy. Increasing resistance in India, we are having resistance patterns are changing. Metronidazole has been at 70-80% mark. Clarithromycin is increased from 17 to 34%, and it is variable. I'll just show you the data for that. Levoflox resistance is also increasing. Amoxicillin resistance is also increasing. Tetracycline resistance is going down, I think, because we have been underutilizing tetracycline, various other things. Earlier for tropical sprue, we used to keep giving tetracycline. So nowadays that has also shifted to quinolones. So tetracycline may be another drug which is now re-emerging for use in H. pylori treatment. So we did a task force on uninvestigated dyspepsia. Dr. Amit Datta was also an important part of it. So we had enrolled 1,187 patients. 424 had organic dyspepsia in the sense that they either had H. pylori or had other endoscopic findings. Endoscopic findings were seen in about 50 people. 17 had ulcer, 3 had a growth, 31 had a polyp, 160 had antral gastritis, and 785 were normal, giving us a rate of about 30% H. pylori positivity among patients with uninvestigated dyspepsia, which is fairly high for a country like ours. And we used LAMP PCR, which gave us result within 1 hour. It told us about the presence and the resistance pattern of H. pylori. And we found that of the 635 patients who were H. pylori positive, by RUT, 276 were positive by RUT and 359 were negative. Of the 635 who were tested for H. pylori by RUT or LAMP PCR, 276 were positive for RUT and 359 were negative by RUT. But among the people who were negative for RUT, 54 tested positive for LAMP PCR, telling us that the molecular diagnostic tests are more sensitive than just standard RUT for picking up H. pylori. So here, what we feel that we should do RUT in all patients, and if RUT is negative, if our index of suspicion is high, we should be testing it by molecular methods in our country. We also found that clarithromycin resistance was there in about 35% of our patients. And when we map it according to the various states, you can see in PGI, we had 467 patients. Clarithromycin resistance was 9%. From Dr. Amit Datta's center, we had 208 patients. Clarithromycin was 40%. From Bhubaneswar, AIIMS Bhubaneswar, clarithromycin resistance of 5%. Calcutta 8%, SGPGI Lucknow 57%, AIIMS Delhi 6%, Choitram 1.3%, and Trivandrum 5%. So you can see that clarithromycin resistance is highly variable according from center to center. So either we have to test for it or we have to avoid clarithromycin as our first line. Another very important thing is patients who are being seen in Chandigarh are not only coming from Chandigarh, they are also coming from adjoining areas. People who are going to Vellore are not coming only from Tamil Nadu. They are coming from Andhra Pradesh. They are also coming from West Bengal as well as the Northeast states. So what data they are showing does not represent only their center. It is coming from various parts of India. So H. pylori resistance, a recent review, primary resistance over the last 2 decades, a systematic review shows that there is an increasing resistance in India, and you can see amoxicillin resistance is also going up. Metronidazole resistance is already very high, but tetracycline resistance is very low, the green bar, and we are hardly having any rifabutin resistance, and levoflox resistance is variable, is about 10 to 20%. So this is a previous study from India, which has shown again variable resistance across variable states from India. So I think in India, A, resistance is increasing. B, there is a lot of variable resistance. So we have to see how to choose our antibiotics. And this study shows that this is the green line, which is the levoflox resistance. Over a period of time, it has started showing a rise. Clarithromycin resistance is also on the high. And we can see that the metronidazole resistance has been persistently high, so it is not a drug to be used. And we have furosolidone is a drug which has low resistance pattern, which can be used. Tetracycline resistance is also low. So furosolidone, bismuth, tetracycline are 3 drugs which we have on hand. Metronidazole, levofloxacin, and clarithromycin are drugs which are not very efficacious given our resistance patterns. So this is the meta-analysis which has shown that 80% people are resistant to metronidazole. Clarithromycin resistance is 25%, but you can see the variability across several regions. You can see that you cannot look at the patient and decide what is their resistance pattern. And as I said, that many of these studies have included people from all surrounding areas and patients seeking care across their states. So we really cannot extrapolate any particular study to a particular region. We can only extrapolate it to that particular institution. Amoxicillin resistance also 25%, but variable across several regions. Tetracycline resistance is low, 5%, except for this outlier study, which showed every resistance to be about 100%. So I would just discount this study for our understanding, and tetracycline resistance is fairly low. Levoflox resistance again variable, but it has gone up to about 40%, and furosolidone resistance is also 10% only, and it is not so variable. So our second line empirical therapy, we have to realize whether we should go empiric or tailored. I think in India, we have to go empiric. It is practically not possible for us to culture and do molecular tests. So our second line therapy should be empirical. And after that, we should be testing either molecular or culture based before we give the third line therapy. And empirical therapy has been shown in several studies to be a more cost effective option than giving tailored therapy. And whenever available, we should be having resistant testing. So amoxicillin and clarithromycin. But now if we shift it to vonoprazan, amoxicillin, and clarithromycin, and then the second line can be vonoprazan, amoxicillin, tetracycline, and to this we could add bismuth, and then the third line will be rifabutin-based therapy. I do not see a great use of levofloxacin for the eradication now, unless we have tested for the susceptibility. So what are the emerging novel therapies? There are several novel therapies which are emerging very interestingly. One is nano-based technology to deliver the antibiotic into the biofilm, vaccination to improve the efficacy, probiotics to again break the biofilm and improve the efficacy, and stimuli-based biomaterial. That means you give the tablet and it stays in the stomach, and you manipulate it with enzymes, pH, magnet, light, ultrasound, various ways to ensure that the drug delivery stays in the stomach. So one of the important challenges of treatment of H. pylori has been that we want the drug to stay within the stomach and not get absorbed and get into the systemic circulation. So these kind of stimuli-based biomaterials have been allowing the drug to stay for a longer time in the stomach or penetrate into the biofilm so that it gets into that niche area between the mucus and the epithelial cell to kill the H. pylori. Rifabutin is very good because it gets to 10 times increased concentration in that niche area. So these are the newer drugs which are emerging. And as I said, tackling the biofilm is important, and handling the efflux pumps by inhibiting them is important. So newer antibiotics, people have tried oral aminoglycoside delivered as nanoparticles. Probiotics has also shown to be helpful in improving the eradication rate by about 10%, and it reduces gastritis and reduces the risk of precancerous lesions. And also probiotic helps in reducing the dysbiosis which happens because of antibiotic. So, but I would think that whether we should give probiotic with the antibiotic or just after the antibiotic is a matter of debate, but with the antibiotic, it helps in H. pylori eradication. After the antibiotic, it helps in preventing dysbiosis. Vaccination boosts the IgA against the H. pylori epitopes, and this may be an important way to go in a country which has 50% infection with H. pylori. Stimulus responsive biomaterial, as I said, allows the drug to stay in the stomach for a longer amount of time and can release ROS in the mucus layer of the stomach, and thereby increasing the efficacy of eradication. And as I said about the nanoparticles and release, which is happening by a stimuli. Phage therapy has also been used, and increasingly there is a role of virus in our management of bacteria over a period of time. In another 2 decades, maybe we may not be using antibiotics to quell bacterial infection. We may be using viruses to quell bacterial infection, and phage therapy may have a role also in H. pylori therapy. And there are antimicrobial peptides which can also be given and delivered locally. Also, changing the microenvironment of the H. pylori helps in suppressing H. pylori. So if you increase the local concentration of H. pylori, it results in better lysis after triple therapy. And so locally increasing the oxygen concentration is going to help in eradicating H. pylori. Presently, it is experimental. People have also used reducing agents like vitamin C and sodium sulfite. So here is a diagram which shows that in the microaerophilic environment, the bacteria is getting into the system. But if you make it an hypoxic environment and remove the oxygen, then there is more of inflammation. So approach to therapy, low clarithromycin resistance, if it is documented, we can use PPI amoxicillin clarithromycin or vonoprazan amoxicillin clarithromycin minimum for 14 days. So how do we know there is clarithromycin resistance or not? Either we test it or we ask for history of clarithromycin use in the last 1 year. Or if the patient is coming in for first time therapy, this is the set of patients where we can use PPI amoxicillin clarithromycin as we have been using. If this patient doesn't respond to that, we can use bismuth-based quadruple therapy, or if there is a high clarithromycin resistance. So these things are going to change with the entrance of vonoprazan into our country. So if we replace PPI here by vonoprazan, we may improve efficacy at this stage and replace the clarithromycin maybe by tetracycline. Levoflox-based quadruple therapy is useful in the West, but in India, we may have problems with 40% resistance with levofloxacin. And our third line is very clear: vonoprazan, amoxicillin, and rifabutin, or vonoprazan, rifabutin, and bismuth may be the way to go ahead in multi-drug resistance. If you do not know the status of clarithromycin resistance, as in most of our patients, we can try bismuth-based quadruple therapy. This is what the Maastricht 6 also recommends, that we should use bismuth whenever we do not know the resistance pattern to clarithromycin. So if this fails, then we can use, and there's high fluoroquinolone resistance, then we use rifabutin if bismuth quadruple fails, or if there is a concomitant therapy, and we can if there's concomitant therapy, if that fails, we can then try bismuth. And then if there's fluoroquinolone resistance, we go towards rifabutin. If it is not resistant, we take the levoflox route. If that also fails, we can try the rifabutin triple therapy. So to improve the efficacy, we can add bismuth, we can add probiotics, we can replace the clarithromycin by quinolones or replace that by tetracycline. and replace PPI by vonoprazan. How do we test for eradication? After you complete the therapy for 2 weeks, if the patient has a gastric ulcer or a duodenal ulcer, you continue with PPI for another 2 weeks. If they don't have gastric ulcer or duodenal ulcer, then there is no need to continue PPI. So we just give treatment for 2 weeks, wait for 4 weeks without any therapy, and repeat the urea breath test or the stool antigen test. And as I said, if you did have a gastric ulcer or duodenal ulcer, it's a good practice to go back in again with upper GI endoscopy. At that time, we can do a rapid urease test. Testing for eradication is mandatory because do not think that your drug has been taken adequately by the patient. In a way, he has been compliant to therapy, as well as the drug has worked and eradicated the H. pylori. So recurrence is a problem which we have considered earlier on, but I think most of the H. pylori, after we give antibiotics, gets suppressed and gets into that spherical cocoid form and may stay there for very long and may again re-emerge when the condition becomes favorable for the H. pylori to come back, and it is quite often recurrence rather than reinfection. Though we live in an environment which has high fecal-oral transmission, reinfection is a possibility, but several studies have shown that even after we give our therapy and the patient is documented eradication, PCR studies may still continue to be positive, suggesting that the cocoid form of the H. pylori may still be persisting after we give our therapy. So recrudescence can happen within 12 months. And if it is after 12 months, we consider it as a reinfection or it coming back from its cocoid form. So what is the Indian perspective? We have high clarithromycin resistance, high metronidazole resistance, low resistance to amoxicillin. Levo is actually increasing to about 40%. That is the recent data. Tetracycline is low and furosemide is low. And region-wise, there is variability for clarithromycin and amoxicillin resistance. And the choice of therapy is to be based on the local resistance pattern. We have to remember that patients from all regions are visiting hospitals across the country. And we have a lot of over-the-counter antibiotics, and lack of antibiotic policy promotes excessive antibiotic use. Drug resistance is common, resistance is variable, and it is changing every decade. So we have to monitor its resistance. Cost and compliance are issues. Single antibiotic should not be advocated. We should closely monitor 14-day therapy with vonoprazan or 2 antibiotics should be the way forward. Bismuth should be a part of all our H. pylori treatment regime. So test before you treat. Treat if you find H. pylori. Use only standard combinations. Ensure compliance. Only 14-day to be advocated, not short of 14 days. Check for eradication always. Testing for resistance in selected situations. Also choose high dose PPI or vonoprazan, and choose new generation PPI like vonoprazan, esomeprazole, or rabeprazole. There is no role of pantoprazole and lansoprazole and omeprazole in today's day treatment. Choose a higher dose amoxicillin, minimum 2 grams a day, and add bismuth 120 milligram 4 times a day or 240 milligram twice a day. Replace clarithromycin, as I think clarithromycin, we do not know the resistance pattern in particular states, and it is actually increasing. And we can replace it by levo or tetracycline. Do not use metronidazole, and consider rifabutin if resistance is suspected. Thank you.
Thank you, Dr. Usha. Dr. Amit, we have 10 minutes more for question and answer, and I'm sure there will be a lot of questions coming up now. But it was a wonderful talk, and many, I think now many questions already posted there are answered already. Dr. Amit, please take it forward.
Sure. So thank you, and that was an excellent presentation, really comprehensive and clear, and I think all aspects have been discussed. So I'll take some of the questions posted. I think Dr. Matthew Philip, couple of questions he asked, I think already you have answered about the what regimen should we choose in treating, and should we test after we treat the patient. Now, also the other question Dr. Matthew Philip asked is there a possibility of transmitting H. pylori during endoscopy or the use of accessories?
Yeah, very important question. There was a study which showed that gastroenterologists had the highest seropositivity for H. pylori compared to non-gastroenterologists. So wearing a mask is also important because aerosols may be there. And the surface of the scope should be cleaned by enzymatic disinfectants before putting it to chemical disinfection. This is a practice not followed regularly at all centers. And I think it's a very important message for all our endoscopists to add enzymatic disinfection before chemical disinfection. So after you take the scope, clean the scope on the outside with a gauze, then use an enzymatic disinfection on the surface of the scope as well as through the channel, wash it with water, and then put it into glutaraldehyde or OPA, whatever we are using, for adequate amount of time before we use it for the next patient. So endoscopic transmission is also a problem in our country. I don't think it has been clearly investigated in that fashion.
Also about, Dr. Matthew asked about probiotics. So the probiotics are released in the intestine, whereas H. pylori is in the stomach. So he's asking how does that help with the stomach bacteria if it's going to be released in intestine?
Yeah, so that's why I suggested a lot of caveats over probiotics, despite a lot of industry advocating it. The actual additional efficacy is only 10%. And if at all, it may have a role in biofilms. People are extrapolating it from colonic biofilms rather than gastric biofilms. So I do agree with you that the real life efficacy of probiotic has not been sufficiently tested as much as it is claimed.
And one also, I think one mechanism
Dr.
say
there
is
are
that,
so many other, there are so many other
Sure, sure.
questions. Don't
Yes,
take
yes,
my
I will take.
questions.
Yeah, no, I will take the next question. So no, I think, okay. Ma'am, the next question is, what is the data on CS stomach and H. pylori from India? Will eradicating H. pylori reduce CS stomach? I think that's something, ma'am, you are passionate about. So what's your response on that? Yeah.
It is a moot question, Dr. Amit. The problem is that we have some protective factors in India, maybe the spices that we eat, or maybe our dietary pattern, maybe lack of smoked vegetables and smoked meat in our country. So there are certain protective factors we are having, which is reducing our H. pylori induced gastric cancer on one hand. But we cannot get away from the fact that most of our patients with CS stomach, H. pylori is the dominant cause in the pathogenesis of those. So I do think that not all of our patients with H. pylori are going to land up with CS stomach, but a significant proportion will land up. And from the way we look at data from East Asia, the way they have gone is to eradicate H. pylori. So I would think that even if we don't go to the masses to eradicate, we should test the patients who are coming to us and eradicate if we find.
The other question is like, is the role of continuing PPI after completing the H. pylori therapy, or should we give PPI for longer or just stop it with H. pylori therapy? That's another question in the chat box.
So if you have gastric ulcer or duodenal ulcer or reflux esophagitis, in these kind of situations, we should give PPI for 4 to 8 weeks after we have eradicated H. pylori. But otherwise, if our aim is to only eradicate H. pylori, only 2-week therapy is recommended.
Okay. Other question is about, in some papers, what they've said, metronidazole dose can be very high, 2,500 milligram per day, 1,500 milligram per day. So what's your take on that high dose metronidazole?
Metronidazole, we have 80% resistance. If we increase the dose to that much, compliance will go down with that bitter taste in the mouth. Patients may not comply. So that is a big problem with metronidazole. And I think going to a high dose is not going to be very beneficial in our country.
One thing they say that for quadruple therapy where bismuth is there, metronidazole, even if the resistance is there, the efficacy doesn't come down that much. So I think when you have a bismuth quadruple therapy, that's one situation people are using metronidazole. What's your take?
I do think people are using, but I find that the compliance falls, because if you want to give 2-week therapy, that is 14-day therapy, giving with metronidazole and clarithromycin with bismuth and PPI, patients actually may report compliance, but I would be very skeptical whether they have actually taken that medication. So 2-week therapy with high dose metronidazole is not really the option.
There are questions coming up about diagnosis, but we'll take them later after the therapy related questions. So what drug should be used in a child A versus B and C cirrhosis. So somebody has cirrhosis, child A versus B and C. If you want to eradicate H. pylori in them, any specific choice for drugs in that setting?
I would think that vonoprazan is safe unless there is severe hepatic impairment. PPIs like esomeprazole is safe. Amoxicillin is safe. Levofloxacin is safe in such a situation. Bismuth is again non-absorbable, so that is safe. So I think but tetracycline also should be okay unless there's severe hepatic impairment. So if it is not a child C cirrhotic, I would not be too worried about my choice of antibiotic.
And the other question, is there any role of intravenous versus oral drug, intravenous regimen for treating H. pylori? Is there any data on using them instead of the oral regimen?
Intravenous drug, I don't know, only a few drugs will get secreted back into the stomach. Ultimately, we want it to be secreted into that area. Now, so we have a problem on this side. We want the drug to go past the mucus layer and stay in the stomach for a long time. And from that side, we want it to get secreted into that area. So we are in a catch-22 situation, but I would think that giving it orally and letting it facilitating its placement between the mucus and the epithelial layer would be the way to go rather than get it systemically, because many of these H. pylori are not invading the patient, they are in that area.
Dr. Usha, this is actually in the context of a patient having a gastric outlet obstruction or outlet compromise due to a duodenal ulcer, and you are suspecting H. pylori or you have proved H. pylori. How do you treat? Will you give orally or you would like to give intravenous?
Sir, I think even in gastric outlet obstruction, if there is an NG tube placed or there is patient is still can take with a half glass sip of water, the drug will stay in the stomach and act locally. So I don't see that as an indication for an IV therapy.
I do agree that this is a question asked by some delegate. So
you also showed about this PCR, which we use for the study to clarithromycin. So do we have something like a multiplex PCR where we can look at more resistance in the same test? Is it possible to do that? Because we have problem with so many drug resistance in our country, as you showed. So the question is, can PCR show drug resistance for other drugs as well?
People have developed multiplex PCRs for levo and clarithromycin resistance. People have developed that, and there's a Spanish study which has done that. We are collaborating with our Korean counterparts and asking them to add the levofloxacin also to the LAMP PCR. They have successfully done it for the clarithromycin, but if we add the levo to that, I think in our country it may be a good idea. Another way to go in our country is to not give clarithromycin and levofloxacin for the next 5 years. We will again get sensitivity to that and use now tetracycline and bismuth till we give a phase for H. pylori for about 5 to 10 years without clarithromycin or levofloxacin.
I think we are running short of time, Dr. Matthew. So I think the remaining questions, I think we'll leave it. Most of them we have covered. So over to you, sir, Dr. Matthew Philip. Yeah.
I think, it was a wonderful session and a good number of participation. I have seen people even from Malaysia joined in this webinar. It is so great to know that. And this is actually a wonderful session. I'm sure the YouTube is available after some time, so people can even listen to it later, because there are a lot of data on that. You have, the Professor Usha, you have done it so well. That's a completely comprehensive. So it's as good as reading so many reviews and all the latest literature. I'm so happy that you have covered 1% also in a very good way. And that is probably, and another message which you have given is that PCR could be the way forward to look for difficult situation diagnosis and even for drug resistance. I think it is very important message. And Professor Amit Datta, you have done a wonderful job. And I know that is time difference in New York and where you are now and in India. So you have done it so well, and you are the apt person to moderate this because of vast experience in this field. So we had a wonderful session, Nisha, and this is this is an ongoing series of masterclass, and we are coming up with another session soon. And this is actually after 2 weeks. This is on August 11th. We have approached a patient with a chronic abdominal pain, and it will be delivered by Dr. Makaria, and Dr. Suli will be the moderator. So I request all of you to join again, and I also request the PG students not to wait for YouTube classes, but you listen, interact, try to ask questions, because it is very rare to interact with such great people. So it's really difficult to get these people on stage to discuss for 1 hour time. This is actually a 1 hour lecture. This is actually a complete education on this particular topic. Thank you so much, and bye.
Thank you so much. Really enjoyed the whole process. Thank you.
Thank you, Amit. Thank you, Usha.
Thank you, ma'am.
And
Thank
my email address can be sent to the participants in
Yeah,
case
yeah,
any
yeah.
questions they can.
We will do that. We will do that.
Thank you.
Thank you so much.
you, sir. Thank you. Bye. Thank you, ma'am.